Good morning, good afternoon, good evening, everybody joining us from around the country and around the world. I am really excited to be with you today. My name is Anna Yaffe, and I'm an emergency medicine physician at Emory University. I'm here representing NETEC. NETEC's mission is to set the gold standard for special pathogen preparedness and response across healthcare systems in the US, with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. The mission is achieved through the collaborative efforts of 13 regional emerging special pathogen treatment centers across the country. More than 100 industry leaders representing a range of healthcare specialties, from infectious disease clinicians to emergency medical services leaders, share their expertise across NETEC's 15 national work groups and 9 task forces. NETEC leverages the knowledge and experience of its regional partners to produce timely and innovative educational resources, provide technical consultations and assistance, and build a nationwide special pathogen research infrastructure and convene global partners. I am very excited to be joined for this webinar with experts from several NETEC regional special pathogen treatment centers. We have Dr. Jonathan Grine, Dr. John Horton, Vicki Herrera, and Carrie Love. After they have presented on their topics in this webinar, we will move to questions and answers. Please feel free to put any questions and answers you have into our question and answer tab at the bottom of your screen, and we will attempt to answer as many as we can in the time we have. I'm now very pleased to present our first panelist. Dr. Jonathan Grine is an infectious disease physician and director of hospital epidemiology at Cedars-Sinai Medical Center and oversees the special pathogens program at Cedars-Sinai. Welcome, Dr. Grine.
Hi, thank you so much for having me. And just very quick apologies, as a last minute technical issue, my camera won't work, but everything else hopefully should be working fine. So with that being said, if you please advance to the next slide, it's really an honor for me to be here with my co-panelists here. I wanted to just begin this by giving a quick overview of the global landscape and then narrow in on some of the recent updates with regards to epidemiology for Mpox in the US. So at a global perspective, when we look at the Clade 2 outbreak, as you can see here, close to 100,000 confirmed cases over 118 countries, and sadly, 184 confirmed deaths that have been reported to date. If you go to the next slide, what does this look like in the U.S. to date? There have been over 32,000 U.S. cases, sadly, with 58 associated deaths in the United States. As you can see from the graphic below provided by the CDC, the vast majority of cases are involving men, largely in the middle age group. To date, most cases have been linked to sexual contact, very close contact. And though I don't have data on this particular slide, just to note that there has been a disproportionate impact in our Hispanic, Latino, and African American populations for this outbreak. So what have we learned from some of the closer investigations from more recent U.S. Mpox activity? I would categorize this, if we considered 2022 the year when Mpox boiled over, so to speak, I would say that we are currently simmering with our activity. And unfortunately, in 2024 to date, there has been an increase in activity compared to 2023. So you can see current numbers through 2024 year to date, over 1,100 cases that have been reported through June 8th. And I wanted to point at a couple studies that have been published on some recent activity. The first here on the left, looking at Chicago, which evaluated recent uptick in cases March through June of 2023. What was notable from that investigation was that more than half, 57% of those cases, occurred in those that had received both doses of the vaccine, who are considered fully vaccinated. The good news from that report was none of those cases required hospitalization. However, there was investigation done to understand those cases that occurred, particularly in those that were fully vaccinated. One thing to note from their observations were those that had received both doses of the vaccine did seem to have high risk activity, meaning more sexual partners in the time closer to their diagnosis compared to those that were not fully vaccinated. And that may have partially explained the issues. They did not identify any vaccine abnormalities, either from the storage of the vaccine or any changes or abnormal responses to the immune response to the vaccine. And also importantly, did not identify any significant viral molecular changes that could have been associated with breakthrough infections. So what I think the main finding from that is that breakthrough infections can occur despite vaccination. However, of course, it does appear that vaccines can still be protective, although not completely protective. Another case study from Los Angeles was done over the summer of 2023. And in that particular uptick, 29% of cases did occur in fully vaccinated people. And amongst those, none required hospitalization. They did identify also 2 cases of reinfection that occurred 10 months or more after their initial infection. So just as a reminder that immunity from either vaccination or from prior infection is protective, but not completely protective. And the other point I would make from that is all cases occurred in males. 80% identified as gay or bisexual. There were also in that evaluation no significant viral changes, mutations that would have been associated with breakthroughs from that investigation. So, of course, in the news, as likely most of you are aware, there has been an ongoing outbreak in the Democratic Republic of the Congo with a clade 1 Mpox. The reason that this is important is that clade 1 is different than clade 2 and has been associated with a potential higher risk of serious illness, potentially more transmissibility. So this is why there's a lot of attention being paid to this outbreak. So a recent publication is cited below, which I think provided a very nice analysis of the outbreak as we currently understand it. You could see over 19,000 suspected clade 1 cases since January of 2023. What's notable about this outbreak, however, is that there seems to be multiple modes of transmission that are driving the outbreak. It is not one mode of transmission. So they are seeing zoonotic transmission, they're seeing household transmission, and in some areas they are seeing sexual transmission, like what has been described with clade 2. So this is really a heterogeneous outbreak. The other really notable fact about this outbreak is a very disproportionate impact on children. You can see that 67% of cases and 78% of deaths, sadly, have occurred in those aged 15 or younger. Some genetic analysis from this outbreak has identified that this is likely from multiple introductions from animal hosts. And again, just pointing out that this appears to be a very heterogeneous outbreak, but one that we are watching very closely. So what about clade 1 in the US? So importantly, there have not been clade 1 cases identified in the United States today, or really outside of the outbreak zone that I just mentioned, at least as of to date. There has been US surveillance processes put in place to try and identify potential clade 1 cases, and that has included testing of various Mpox specimens collected across the United States. It's also included wastewater surveillance and airport testing. And I will point out that most tests available are not able to distinguish between the clades. However, some labs will offer clade-specific testing. I believe my colleague will touch on that more a little bit later. But I think the key message here for us in the US in particular is that clinicians really should be asking about travel in any suspected Mpox case. And if there is a patient who has recently traveled within the last 3 weeks from Africa, from the DRC in particular, that should prompt evaluation for clade-specific testing, and that would typically be done through, for example, local public health. Now, one thing that is important to note is that the treatment and prevention guidelines, PPE recommendations, are not different for clade 1 than clade 2. So with regards to clinical management, it is really not clade specific. We would still recommend the same treatment recommendations, same PPE, and also it is presumed that the vaccine will be equally protective against both clades, at least as far as our understanding is right now. This is a moment to just kind of remind ourselves about the concept of identify, isolate, and inform, which has recently been incorporated into newer Joint Commission requirements. But this paradigm really does work well for diseases such as Mpox. So I think the emphasis for all of us should be ensuring that our frontline staff are familiar with the signs and symptoms of Mpox, as well as the risk factors associated with it. If a patient with those signs or symptoms and risk factors is identified, that those patients are immediately separated from others. Staff have access to the appropriate PPE, which in this case is gowns, gloves, an N95 respirator, and eye protection. And that appropriately, the local infection prevention, as well as your laboratory staff, are informed about the case, and also local public health would be looped into those potential cases. And I think, again, here highlighting that this is, again, where travel screening can be very important. If there is somebody that has recently traveled from that outbreak zone for clade 1, which is currently the DRC, that should prompt additional evaluation for clade-specific testing. So just wanted to spend a few minutes on the clinical presentation, and I'm going to go through this a little bit quickly. But there haven't been any significant changes to the typical presentation as far as how we understand it. There's an incubation period of around 3 to 17 days in which patients are not considered infectious. There is a prodrome period that is experienced by some, but not all patients, that may last for 1 to 4 days. Fevers, malaise, and headaches, and notably lymphadenopathy are prominent with that. But not all patients may have that, and some may present just with the rash. The rash kind of classic pictures are shown here. You can see that it'll evolve from a macule to a papule to a vesicle to ultimately pustules. And patients may present with as few as 1 to sometimes several lesions across their body. And then, of course, there's the resolution phase. For once the lesions have completely scabbed off and there has a fresh layer of epithelialized skin underneath, they would no longer be considered infectious at that point. I did want to highlight what we have learned about severe Mpox, and unfortunately, we have seen cases of that in the U.S. Advanced HIV is really the major risk factor. There was some studies I'm citing here looking at 38 Mpox-associated U.S. deaths, where you can see the vast majority occurred in HIV-positive patients, almost all with a very low CD4 count, and typically in Black cisgender men, which is the predominant which was the predominant group affected in that study. Also, just showing here, sorry for the graphic nature of the pictures, but to make the point, really seeing how these lesions can become progressive necrotic lesions that will evolve over weeks to months, sometimes despite treatment. And really the major risk factor here is delays in treatment. And really this serves as a reminder that for our most vulnerable patients, we should be aggressively providing treatment. There are other forms of severe Mpox that have been identified, although much more rarely. I've listed here. I'll just point out ocular lesions have been described in several case reports. These can be sight-threatening and should always prompt ophthalmologic evaluation. I wanted to spend a moment on transmission. What have we learned? Again, sexual contact remains the most common risk factor for transmission. In studies looking at secondary attack rates outside of sexual transmission, you could see a low attack rate of about 1.5% for non-sexual close contact. So it can occur, but it is much less common. Transmission in healthcare settings is fortunately been very rare. There have been reports typically associated with either a breach in PPE or sharps injuries. And I want to point out this is really important to note that you should not be using sharps when you're collecting specimens for Mpox testing, as that has been associated with potential healthcare worker exposure and transmission. There has been some interesting studies looking at potential asymptomatic transmission. However, I'd say the jury is still out on how frequently this occurs. There is some seroprevalence data to suggest that there is the potential for either asymptomatic or minimally symptomatic cases that have been associated transmission. But again, the frequency of this is really unclear. I'll try to finish up quickly to give my colleagues time here. Just a few minutes on diagnosis. My colleague will talk on this more, but just to say that PCR testing is much more widely available, either through health departments or through commercial labs. You do need to, however, request clade-specific testing, specifically if there is a patient that has recently traveled to, for example, the DRC, where there's the current outbreak. I would also just remind us as clinicians to always consider testing for concurrent STIs, as there continues to be a very high association with Mpox and other sexually transmitted infections such as HSV, syphilis, and HIV. When collecting tests, of course, using appropriate PPE. It is recommended to collect 2 swabs per lesion, typically from 2 to 3 lesions. You should vigorously swab with a sterile synthetic swab. Don't use cotton swabs, but do not unroof lesions with sharps, as this has been associated with sharps injuries and transmission. Just a few words about treatment. At the moment, tecovirimat is not FDA approved for Mpox. It is approved for smallpox, but that being said, it is widely recommended for people that are at higher risk of severe illness. And so I will just point out here that there are, in general, 3 groups of patients for which tecovirimat should really be considered as potential first line. Those would be patients presenting with severe disease, including hospitalization or hemorrhagic lesions, lesions that are in high-risk areas, such as the pharynx, the pharynx or penile foreskin or the vulva or vagina, because of the potential for scarring and strictures. And then, very importantly, people who are at risk for severe disease. Largely, this has been advanced HIV patients, largely with CD4 counts less than 200, but other patients that may be immunosuppressed, pediatric patients, those who are pregnant or breastfeeding, or those that have conditions that affect skin integrity. And that would include atopic dermatitis or eczema. I will just say very quickly, tecovirimat, the efficacy is still unclear and under investigation. It is available largely through 2 mechanisms, either through an NIH-funded study called STOMP, or through a expanded CDC-approved IND protocol. It's generally provided orally. It is overall fairly well tolerated. There have been side effects associated, including headaches or GI symptoms that have been associated with it, but it's generally well tolerated. It is generally given as a 2-week course. The dosing depends on weight. Longer courses can be considered in those who are immunocompromised. And I'll just say resistance has been described, but it has fortunately remained pretty infrequent and largely seen in immunocompromised patients who have received multiple prolonged courses of treatment. We are not seeing resistance largely outside of that group to date, which is good news. I think the key factor I want to point out is that do not delay treatment in those that are at risk for severe disease or who have severe disease. And I'll just mention that there have been very nicely described published guidelines for how to approach treatment considerations in severe Mpox that I won't go into here, but that you can look at to evaluate when additional treatment may be required. So I will end here and hand it over to my colleagues. I'll just point out that because of the increasing activity in the US and the ongoing Clade 1 outbreak, this is really reinforcing the importance of vaccinating our most vulnerable groups, those that are at risk of contracting this. The identify, isolate, and inform paradigm to help rapidly identify cases and to identify those for which clade-specific testing is warranted is very helpful. And lastly, just remembering that advanced HIV is a major risk factor for this, and we need to initiate treatment promptly in that group. And with that, I'll hand it over to my colleague.
Thank you so much, Dr. Grein, for that excellent overview and current situation of what's going on in the US and around the world with Mpox. I'm now going to turn it over to Dr. John Horton. He's a practicing OBGYN in Emory University's Department of Gynecology and Obstetrics and will be speaking on Mpox and pregnancy.
Thank you. I appreciate it. I appreciate the opportunity of working with the project and also to speak towards special populations. I'm also going to talk a little bit about vaccination overall. So the vaccine itself, especially when regards to pregnant patients, we were talking about the Genus vaccine. The ACAM vaccine is not currently recommended within pregnancy, secondary to it can have potential effects to the fetus themselves. And so we're talking about the initial dose, how do we do vaccines? So initially it was a sub-Q vaccine, but was quickly found and there was a significant change within how the vaccine was given, changing it to an intradermal dose. This was incredibly important because the intradermal dose was 5 times less than the sub-Q dosing. So it substantially increased our ability and supply and ability to distribute the vaccine itself when moving to intradermal itself. especially to those the at-risk population, and specifically looking at those who are greater than 18 years old. It is a 2-dose regimen that are given approximately 28 days or 4 weeks apart. The distribution of the actual vaccine itself and its supply was based on its risk population and allocation by jurisdiction. That is often, you can see, by state and or territory, but not always. Interstates themselves may have their own jurisdiction based off of populations themselves. Overall, right now, the approximate number of total doses given is just under 1.3 million. And as of January 1st last year, there was about a 60-40 split of those doses that were first doses and those that were the second dose itself. This is important because you do receive some protection from a single dose, though the most salient information is on the full regime itself. The first and second dose coverage of the most at-risk population at the time, the paper was written, was around 36.7% and around 23% overall. It's incredibly important to note and be mindful of the health disparities of the vaccine distribution and those that received the vaccine. The highest population was almost reversed from those that actually contracted the disease itself, being highest among Caucasian non-Hispanics, then Latin or Hispanic men and or those within the transgender community, and then those are African American and Black community, where the actual disease itself was seen almost in a flip of that. And so it brings about really important thoughts and how do we approach vaccine education? How do we approach vaccine distribution within the communities that are at most risk? And how do we get the therapies to the people that need it across in an equitable fashion? The vaccine can be used in a post-exposure prophylaxis way. It's best if given within 4 days, but can be given within a 14-day exposure. And so there is that 2-week sort of window. After 14 days, the actual benefit is not really known. The criteria for getting is within the gay, bisexual community, or men who have sex with men, transgender, non-binary, those who have had within the last 6 months either a new diagnosis of an STD, more than one sexual partner, or a sexual those who will use sex as a commercial sex venue, those who are sex workers, sex associated with a large public event. And like, what does that mean? Well, within all populations, including the LGBTQ plus community and queer community, there are events where there's increased sexual behavior that we know occurs. There may be events also completely centered around sexuality and the interactions among people within specific communities. And so just being mindful of those who not only have attended, but actually think are going to those events themselves. Those who have sexual partners, who have people who have the risks that are above. And so it's important when doing sexual history as a gynecologist to make sure that we're asking the right questions. It is important to know that those men who have sex with men, or those within the transgender community, they may not identify as gay or bisexual. And so we have to ask who are their partners specifically. For pre-exposure vaccination, there are people can get the vaccine who are at occupational risk of orthopox viruses, and it's specifically those for 18 years and older at risk for Mpox. But it is important to note there was some controversy at the initial time, and even now under the recommendations of, I was seeing patients that like who can get the vaccine and who is at real risk. It's important to know, as just presented well, that occupational acquisition of Mpox is actually incredibly low, was most commonly with the use of sharps. And so it actually isn't recommended as a routine vaccination for healthcare personnel unless they also have sexual risk factors as well. For pregnancy, the data is very limited, and this is a very common thing that we as OBs run into, that our population may not have the data to have clear and clean guidelines of exactly what to do and what what ifs. We do know that it can be transmitted during pregnancy itself. One of the primary questions that came up is, what if somebody had an outbreak in genitalia at the time near delivery? We don't currently have information of whether offering a C-section will change the overall the acquisition rate of the neonate. It is important to know that if there is genital lesions, that we should have a shared decision making with the patient, knowing two interesting things. That though we don't know if a cesarean will change because we don't know the Mpox virus within vaginal secretions, within all the other bodily fluids that may be present during time of delivery. We do know that after delivery, the recommendation is isolation of neonate and mom, knowing there is good data that shows having together improves outcome. This is one of those small times we consider separation. And so knowing those things, we should consider that if there's genital lesions, talking with the patient about those potential risks and what we do and don't know and coming up with a delivery mode and plan. There is, as I just discussed, consideration of isolation and breastfeeding. If some patient, there's encouragement to start breastfeeding, that we pump and dump during that time, and we counsel patient on how to best and when to reunite the birthing parent and neonate as soon as possible, as soon as safe. Treatment within the pregnant population, do consider post-exposure and pre-exposure vaccination within the right risk populations. Tecovirimat, Mpox is first line. The safety data is not known within the pregnant patient. It has not been seen to have adverse effects, at least in animal models. It is found in breast milk, but it's important to know that we're separating the consideration of breastfeeding initially. It's the amount known in the amount known of dosage in breast milk isn't enough to be considered treatment therapy for the neonate or a child, and so they have to be separately treated. Thank you very much.
Thank you so much, Dr. Horton, for sharing about the special population of pregnant persons in Mpox. I'm now going to turn it over to my colleague, Vicki Herrera. Vicki is a clinical laboratorian and a research coordinator at the University of Nebraska Medical Center in Infectious Diseases. She has supported the Nebraska Biocontainment Unit for the past 13 years.
Thank you, Anna. I appreciate the opportunity to speak with all of you today about some of the lab considerations. As Dr. Grind discussed earlier, there is a molecular testing available in the form of PCR to detect Mpox. This is currently the only method that's recommended for individuals with a current infection and is actually the fastest method at the moment. So some public health laboratories, as well as regional treatment centers, can offer those, as well as some commercial laboratories. It's best to reach out to either your public health laboratory or your regional treatment center to discuss what they offer. And as was said earlier, clade differentiation testing is not available at all sites. So again, that's where you need to reach out to your public health labs or your regional treatment centers for them to help you determine where would be the best place to send those specimens. When talking about specimen collection, ideally, you'd want to collect at least 2 swabs from 2 different locations. Those swabs should be placed in 2 different tubes of viral transport media, but each laboratory has their own specimen specifications. So again, reach out to those laboratories for them to tell you what those specifications may be. And make sure that the tubes are labeled appropriately with all the patient information, as well as the location that the swab was taken from. NETEC does have a specimen collection video available on their site that you guys can access for additional information. One of the exciting changes that just came down as of March 11, 2024, the Department of Transportation has updated the shipping classification for Mpox. So diagnostic samples for both clade 1 and clade 2 are now currently classified as category B. So make sure that you have someone trained to ship category B specimens in your facility, but this makes it much easier to get diagnostic samples to the laboratories of choice. Please note with shipping considerations that clade 1 Mpox cultures are still considered a category A. So those would need to have special shipping regulations, special people to ship those that are trained and certified in order to ship those. So as Dr. Grind had mentioned before, when we talk about the 3 I's, the identify, isolate, and inform, it's very important to make sure that you inform your laboratory of the type of specimens that may be headed to the lab, whether that's at your own facility or that's at a lab that you're shipping specimens to. So clade 1 cultures are still considered a select agent and should not be performed in the clinical lab. So when at all possible, please avoid cultures of Mpox. Keep in mind that Mpox lesions and lesion fluid have higher viral titers than other body fluids and should be treated with caution. So in addition to your normal laboratory PPE, make sure that your PPE cover your mucous membranes. Again, as discussed before, having your eye protection N95 and whatever your laboratory deems appropriate when working with those specimens. Utilize your biosafety cabinets whenever possible and avoid aerosolizing procedures also whenever possible. Your laboratory, if you're doing anything in-house, such as your normal routine laboratory tests, please do a risk assessment to determine if additional precautions are needed above the standard precautions when testing non-lesion specimens. Again, those lesion specimens are going to have a higher viral titer, so extra precautions may be needed for those that may not be needed for some of the other laboratory specimens. Thank you. I'm going to turn that over to Dr. Yaffe again.
Thank you so much, Vicki, for that presentation. I'd now like to invite our last panelist, Carrie Love, who has worked in healthcare for the last 30 years as a registered nurse and now serves as Corporate Director of Infection Prevention at Emory Healthcare, to discuss waste management.
Good afternoon, and thank you so much for having me today. I'm honored to be presenting with my group of colleagues here. So, as discussed previously, there are 2 distinct Mpox clades, and they've made it easy: clade 1, clade 2. So I think we've covered that adequately. The successful management of the domestic cases of clade 2s that we've done in the U.S. since 2022 has made this change in shipping and handling and waste management possible. So the approaches used to safely manage healthcare generated waste contaminated with clade 2 Mpox can be applied to the management of most generated waste. So with clade 1, so those things like your disposal of soiled PPE, patient dressings, etc., the diagnostic specimens, not the viral cultures, but the diagnostic samples and those types of clinical waste can be handled as Class B. And Vicki's already covered about the Mpox clade 1 viral cultures, and that those must be handled as Category A. The hazardous materials regulations that were released, they were updated in April of 2024. This is a modified table of that, and it really walks you through, classification, packaging, shipping name, inactivation methods, and disinfectants. So those of you interested in disinfectants, you can go to the U.S. Environmental Protection Agency, look at List Q, and anything with that emerging pathogen label claim is acceptable. The other thing I want to point out is there's a link at the bottom that will take you to this document, and I believe Vicki also had it on hers. So you're not alone there, and NETEC also has multiple resources to assist with this. And then I also want to emphasize what Dr. Grind and everyone else has emphasized, is that the identify, isolate, inform piece is very important. And if you're seeing a patient in an ED or a clinic, being aware and then having the appropriate PPE available to provide them the correct level of care is the one thing I think I would want you to take away from this, aside from the good news that we managed the clade 2 so well that we were able to decrease the level of the waste to Category B. And that's all I have for this. Thank you.
Thank you so much, Carrie, for that. We're now in the question and answer portion of our presentation. I will welcome all of my co-presenters to come onto their camera if they are able to. I know there is some internet challenges today, but if you are, please feel free to come onto your camera. And for those in the audience, we do have the Q&A function at the bottom of Zoom, and you can feel free to place questions in there. I also have many questions from pre-registration, so I'm looking forward to having a really lively discussion. It looks like the first question that was in the chat is for Dr. Horton. One of our participants was wondering if you could elaborate a bit more on if there's anything known specifically about transmission through breastfeeding, and maybe a little bit more about isolation, like how long might you isolate a mother and baby?
Sure. It's it is, I think, a hot topic anytime we make this or this recommendation is out there, because I want to make sure that we highlight two things. It is absolutely recognized by greater science as well as clinicians who take care of people, the importance of skin to skin, the importance of breastfeeding, and a recognition that in many experiences of a birthing parent and in the community, that the birthing parent may be the only person that can take care of the newborn. And so I just want to make sure I highlight that we recognize this is incredibly important. But what we do know is that there can be transmission within active lesions from person to person, and that would include from birthing parent to newborn. And so, can lesions be covered? They can, but we do think there is transmission through potential through breast milk. And so it's in all things, these are, what is your current clinical situation? What is your social situation and the support for the neonate, the newborn, that is possible, and also understanding the trauma that is involved, that potential separation, or isolation. And so having a conversation is starting even before you deliver. If you know there is an active infection, is incredibly important to start setting up those expectations. And how are you going to do compensation, some sort of compensatory, to make sure that the two are interacting as much as safely as possible. And so overall recognizing there is trauma here, but setting up that expectation of what do we know, what do we not know, and this is having that shared decision making with the patient based off of how can we keep both the birthing parent and the newborn as safe as possible.
Thank you so much for that. We do have another question in the Q&A. I think this one maybe is for Dr. Grein. Is there anything known about the cases who were vaccinated and had breakthrough infection? Is there a problem with the vaccine, or is that something that's expected in the vaccination process?
No, thank you for the question. It's a great question. This was certainly the big question that was evaluated in the Chicago uptick of cases, where over half of the infections that were noted last year were breakthrough infections. So there was a pretty extensive evaluation of exactly that question, really trying to make sure there were no abnormalities with the vaccine itself, that storage parameters were met. But they also looked at patients' immune response, humoral response to the vaccine. And the outcome of that investigation was there really was no indication that there was abnormalities in the vaccine itself or in the response to the vaccine. I think what the lesson is from what we've learned so far is that while vaccination certainly does provide very substantial protection, that protection is never 100% complete. And there is always a risk of breakthrough infections, and we see that with nearly every infectious disease. Unfortunately, vaccines are never 100% effective. And so it's just a cautious reminder that the vaccines are very important, but they're never going to be perfect. And there was no indication of abnormalities that could be addressed to improve upon that at the moment.
Thank you for that. I do have a question from pre-registration for Vicky. Some of the registrants were wondering if there was any information on any Mpox rapid diagnostics that might be available either now or in the future.
So currently the PCR is the fastest diagnostic that we have. There are some things in development for rapid diagnostics. There is no timeline on those at the moment, but they are trying to work on some things that might be a little bit faster.
Carrie, I have a question about swabbing and what your recommendations would be for someone who has several lesions. If we test only a couple of the lesions and those test results are negative, can we definitively say that person is negative for Mpox, or do we need to do additional testing?
I would highly recommend doing additional testing because anyone that's presenting with lesions or a rash, has obviously something going on, and you want to rule out any other sort of potential disease process that could also be highly infectious. Chickenpox comes to mind, shingles, measles. There's a variety of other things, even though those rashes aren't exactly the same. And I think Dr. Grind spoke to this earlier also. You need to also consider other potential sources for that rash.
Thank you so much for that. Dr. Grine, we had some people, given our experience with COVID and flu and seeing these viruses rapidly mutate. Is that something that we can expect with the Mpox virus? And what should we be looking out for future outbreaks?
Oh, no, thanks for that question. Of course, we would expect any virus to mutate, so I think it's not unexpected to see changes over time. However, I would point out a couple important differences between Mpox and COVID, as an example. Mpox is a DNA virus, and COVID and flu, for example, are RNA viruses. DNA viruses in general mutate at a lower rate than RNA viruses, so I think that's just one thing to keep in mind. Also, fortunately, Mpox circulates at a much lower level in the population than COVID or flu, for example, meaning there's less opportunities to mutate. So those two things I would point out as important differences between Mpox and COVID. But I will just reiterate that all viruses mutate. It is something we need to keep a very close eye on as this outbreak evolves.
Thank you so much for that. Carrie, as a frontline provider myself, and I know I work a lot with pre-hospital care colleagues, and some of them are attending today, is there any special risk for pre-hospital care providers or first responders, or should they do anything additional to their patient care practice when they're in the field?
As we've discussed previously, PPE is your friend. And making sure that you have the appropriate PPE on, gloves, gown, skin to skin contact, those types of contacts are what where transmission is going to occur. So if there's any suspicion at all in any type of rash or patient that you're transporting or seeing in the ED, I would always recommend put on the right PPE, figure out what you've got, and then go from there. I know ER is fast moving and our EMS providers are also fast moving, and I know they do have access to that PPE. So don't be afraid to use it. It's better to use it and not need it than need it and not have used it.
Thank you so much for that. And I think we'd love to hear a corollary question for you, actually, is there any specific questions that should be asked in the field to help pre-hospital care frontline providers identify these patients? How would you suggest they approach that?
Well, we developed, when we started seeing this in 2022, we developed a questionnaire that asked, about perirectal pain and rash, lesions, those types of things, and that helped us to decide what we needed to do with the patient. So we provided that guidance as infection prevention when we would get a call. So those types of questions are things that are very beneficial. And I know there are some published, I believe, algorithms out there now, but I would be more than happy to share the document that we created for our frontline staff as part of our playbook that we also shared with our EMS and ED. So if that's of benefit, happy to do that. but just knowing the right questions to ask. And as it evolved, we learned that asking about perirectal pain and lesions in other places than just visibly on the face or arms was very critical and important.
I think that's so helpful. And also, the NETEC repository has additional resources for the Frontline that you can look through to see if anything is relevant to your own facilities. So that is something I think that's beneficial to see what other places are doing. I kind of wanted to take a moment to have a little bit more of a personal discussion. Dr. Horton, I know as a frontline provider at the height of Atlanta's outbreak, you were able to be vaccinated. I was wondering if you might share with our participants a little bit more about that experience.
Sure, I'm happy to. And I'll answer on the way, I'll answer one more question from the chat of how long to isolate pregnant patients from neonate. The answer is for ACOG, we suggest until all lesions have resolved, the scabs have fallen off, and a fresh layer of skin has formed. But again, lots of discussion to be had. For me, yes, it was pretty significant. I definitely fall within the category and within the risk population, and so I was vaccinated fairly early on. Once the vaccine was available here in Atlanta, where I work. I got mine from a public health department, for which I'm incredibly thankful for, and the workers there. But I will say that there's a weird trauma involved in it. Having a large group of your community lined up in what feels like a sort of corralled situation, like it does have distinct feelings, whether it's fear or fear of living lives, whether living also an open sexual life. It is impactful. I'm also old enough to have grown up in a time where I grew up in the 80s and 90s, and it was really impactful with the AIDS, sort of AIDS epidemic and the continued AIDS needs. And so the idea of sexuality being associated with severe outcomes, and potential long-term effects and death, that still has a resolving a trauma within our community. And so having this come about again, I think hopefully it does help spur hopefully those to seek vaccination when we do have preventative ability for diseases that come up, that sort of wheeled their heads again. But it was really impactful for our community. And again, I will remember being in those lines for a very long time.
Thank you so much for sharing that experience. Having been vaccinated, did it change your clinical practice at all? Did it give you any sense of reassurance, or did you feel confident in your PPE and your isolation?
In general, because I've worked with NETEC for a very long time, I do have confidence in PPE, and I have a great reliance on it as to the verge of paranoia. But I think it's important for us all, and these are great questions that you're seeing in chat, of what do we need to do and how do we protect them, and making sure that busy clinicians know how and have easy access to it. If you're running to a delivery, or you're seeing I'm seeing 30 to 40 patients in a clinic in that day, and I come across somebody, what is the day-to-day, and the importance of day-to-day universal PPE, going into every situation, knowing what you should do, but being prepared as well.
Thank you so much for sharing your experience. Carrie, there's a couple of questions in the chat for you. The first is, what do you do if you have identified a patient who's in a semi-private room?
Well, and I'm actually going to, there are two exposure questions, so I'm going to kind of tie them together here. So in general, patients in healthcare facilities who may have had an exposure and asymptomatic, they don't need to be isolated. They should be removed from that room if that person is known to be an Mpox patient. But they don't need to be isolated. However, they should be monitored for symptoms for 21 days, at least daily. Signs and symptoms need to be monitored for, looking for lesions, etc. If a rash occurs, then you're going to put them on isolation precautions until the rash is evaluated, testing is performed, or if the testing is negative and you've ruled out everything else. So if there are any additional questions about that, but that's essentially if someone is in the same room and haven't had skin to skin contact, the transmission could possibly occur from a healthcare worker, but it's not as likely. So just knowing that if you're monitoring that patient and to try to ease their fears, I think that's understanding the likelihood of that happening is very low, is one of your best friends there as well. And Dr. Grind, please feel free to jump in. I know you have experience with this.
Oh, no, I completely agree with your response. And I'll just maybe add that with regards to kind of transmission in that setting, fortunately, it has been pretty uncommon. But to your point, I think it is important to make sure that any patient who may have been exposed is informed and is monitoring for symptoms. So just to to accentuate that, and also just say that on the CDC website, there is actually a tool provided to help differentiate the degree of exposure, for which if there is a significant exposure, for example, to mucous membranes or non-intact skin, that would be the highest risk exposure, for which you may want to consider post-exposure prophylaxis. Over in most settings, I think we're talking about, you're probably not going to have that high degree, that type of high risk exposure.
Thank you for that. We had several questions about kind of some vaccine logistics, both pre-registration and in the chat. I think these are for Dr. Grind, but feel free to jump in if anyone else has some things to add. The first is about the amount of vaccine. There's a discrepancy on the website versus CDC instructions.
Yeah, and I welcome my colleagues to hop in here. I'm trying to, I think what is the discrepancy might be between the subcutaneous dosing, which is generally 0.5, and the intradermal dosing, which is 0.1. So I think that is what's being brought up. And I at the moment now, in general, subcutaneous dosing is generally the preferred method. It's easier to do, but I believe that is what's being mentioned here.
And then another question about the vaccine. If someone in the past had received the ACAM vaccine, are they eligible for JYNNEOS, or is that kind of like a contraindication to be vaccinated?
Yeah, and I don't know, again, if any of my colleagues would like to speak up on this, but I do not believe there's the contraindication there. It is. But I'll defer to my colleagues if there's anything they'd like to add to that.
It looks like they agree with you. I just wanted to, I know we're reaching the end of our webinar, and I really appreciate everyone's participation, both our panelists as well as the audience members, for your excellent questions. I wanted to reinforce a couple of our resources that we have available. I know there was some questions about sharing algorithms and questionnaires, and I think this is particularly relevant for the frontline. So definitely NETEC has a lot of resources available on the website. And these resources are some of which are listed here. So there's anything from technical support service, which you can submit online or by emailing info@netec.org to actually kind of get additional assistance at your facility. There's a lot of online education and training available, and recorded webinar slides, other educational content. There is additional resources in the resource library, and some of these may include things like frontline signage, additional recommendations, and you can see what facilities around the country are doing in terms of identifying. So I think in the frontline, this is really important to kind of think about your messaging and to hone your messaging in terms of Mpox for your identification, and these are some things that can help. We also have a newsletter that you can subscribe to make sure that you stay up to date on our content. These resources are available for everybody, any healthcare professional, frontline, assessment facilities, EMS agencies, and anyone who might encounter a special pathogen again in their work. Again, you can feel free, if you have questions after this webinar, to email info@netec.org, and you'll directly be put in contact with one of our subject matter experts who can help you with your question or help you work through a conundrum at your facility. And again, the technical assistance request is at netec.org. You can also connect with us on social media and by signing up for the newsletter, so you know more about our webinars and upcoming trainings and new courses. We also have a podcast, Transmission Interrupted, that's available at all major listening platforms. And that's a little bit more informal, includes some storytelling about some of these outbreaks and working with some of these pathogens. We also, again, have the resource library where you can find additional education, training, and the latest research on all stages of preparedness and response. With that, I will close this webinar. Thank you again for listening in, and to our panelists for your excellent expertise and sharing on this important topic. And we look forward to future opportunities to connect with you all soon. Thank you so much.